Kính thưa các thầy cô, các đại biểu và các đồng nghiệp online cũng như là on-site. Như vậy bắt đầu phiên sinh hoạt khoa học thứ hai của sáng nay thì chúng ta sẽ có 4 cái bài báo cáo, sau đó sẽ có cái phần thảo luận. Chúng tôi xin giới thiệu chủ tịch đoàn là có tiến sĩ Khả và thạc sĩ Lâm gần tôi cùng tham gia vào cái chủ tịch đoàn phiên thứ hai này. Cái mở đầu là buổi báo cáo đầu tiên, bài báo cáo đầu tiên về can thiệp tái thông tĩnh mạch trung tâm phức tạp với phần trình bày của bác sĩ Abouelmagd Makramalla từ Mỹ, từ Đại học Cincinnati. Xin mời bộ phận cho phát cái bài ghi của bác sĩ.
Good morning. It's a pleasure to present today at the annual Congress of the Vietnamese Society for Interventional Radiology. Thank you for the invitation. I would like to talk about complex central vein recanalizations in regards to thoracic veins. So without further ado, so I do not have any financial disclosures related to the topic. There's actually a published article from the Journal of Vascular Interventional Radiology that talks about standards of practice and standards of reporting for a total central vein occlusion, and they have great illustrations to classify central vein occlusions, and they were able to classify the 4 different types of total central vein occlusion. The first type is internal jugular vein or subclavian vein obstructed, and based upon the knowledge of the patency of the outer veins, would be subclassified into 4 different categories. Type 2 is unilateral brachycephalic vein occlusion, and again, type 2A and 2B based upon the knowledge of the patency of the contralateral side. Type 3 is occlusion of both brachycephalic veins, and type 4 is SVC obstruction. So this is a case illustration where this patient has advanced stage renal disease with a malfunctioning upper extremity fistula and presenting with upper extremity swelling for the past 2 months. The patient had the left brachycephalic stent that was placed as an outside hospital, and you can visualize here that we are coming through the left upper extremity fistula, and there's still occlusion of the left brachycephalic vein. There is a stent, as you can see here. This stent is actually very small, and there's it's not appropriate for the size of the brachycephalic vein. The patient had severe swelling, and they want to maintain the access through the fistula. So we decided to exclude the stent in the brachycephalic vein. To do so, we actually got access in the right common femoral vein, and we started slowly recanalizing across the left brachycephalic vein outside the stent itself, using the catheter positioned through the fistula as a target. And after we're able to completely recanalize the vein, we pass the wire and use a snare to grab the wire, snaring the wire through and through. We're able to put a glide catheter over the wire, snare it out, and place a stiff wire. And we plastic the vein to confirm that we are still within the vein lumen that was occluded, and we placed a covered stent to maintain patency of the left brachycephalic vein. And the right brachycephalic vein was also patent, was not jailed off. The patient actually had excellent results, and the swelling resolved within a few days after the procedure. This is another patient where it was performed by the interventional nephrology of colleagues, and they referred to us because the patient had a failed left upper extremity graft, but now needs a right upper extremity access, but there is complete occlusion of the brachycephalic vein. We brought the patient, checked the left brachycephalic vein. The patient had a catheter in location. We took out the catheter, and you can see the fibrin sheath from the catheter itself. When we did the venogram through the extremity, we find complete occlusion. We're able to cross through it and put 2 stents and covered stents. And fortunately, we had a lot of the patients who needed central vein recanalization that week, and we actually utilized all our stents. So we only had those 2 side stents, and the overlap was not appropriate. I showed this to our residents and fellows, where you have to have appropriate overlap between stents that are placed. So we were planning to bring the patient back for another overlapping stent in a couple of weeks. Unfortunately, the patient did not wait, came in with some swelling. CT shows occlusion of the stent, so we decided to stent the prior stents, plus new stents, and also double barrel stent to keep them open. So this was after placing those stents and angioplasty, and you can see there's patency of the right brachiocephalic vein stent and patency of the left side as well. Brought him back for a venogram 1 month later, and the stent was open, and we did, and the left side stents were also open. You notice that we did not jail off the left internal jugular vein. So the patient had the graft created 4 months later. Unfortunately, while placing the graft, it clotted, and they had to do a surgical declot while they were placing the graft itself. Unfortunately, they embolized some clots to the stents, and they called us because they couldn't get the clots out. So we went through the right groin to avoid going through a fresh graft that was placed the day before. And as you can see, there's no flow in the stents itself. So we're able to angioplasty and do mechanical thrombectomy of the stents using balloon maceration and the percutaneous thrombectomy device. And we got excellent flow with the patency of the stents and excellent flow through the graft itself. And the left stents remain patent. We checked that. Actually, these stents remain patent for 5 years later, and until 5 years remain patent. And then actually we kept following the patient for 7 years after that, remain patent until the right upper extremity graft failed, and they decided to place a hero graft on the left side. This is another 66-year-old female with rapid upper extremity graft and increased pressures with prolonged bleeding after dialysis. On the CT scan, you can see multiple venous collaterals and the hot quadrate sign in the liver. So the patient had a port that was actually placed because she had cancer, and that has been in remission. So she did not need the port anymore. And you can see that the port is occluding completely the right brachiocephalic vein. So we decided to bring the patient back for a recanalization. This is a coronal where you can see the brachiocephalic is completely occluded around the port catheter. So the first thing these cases we do is we actually, first of all, we check the graft to make sure it's patent, and then we check the central veins. You can see complete occlusion of the brachiocephalic vein and multiple collaterals. We took out the port, and you can see the fibrin sheath for the port itself. And we identified the left brachiocephalic vein to avoid placing the stent across the origin of the left, the location where the brachiocephalic vein joins on the left. So we placed a Viator stent. Actually, in the past, we used to have the 12mm Viator stents, and they were excellent because they had great radial force and their patency was amazing. So, and the nice thing also is that it has an uncovered portion of the stent that it would not obstruct the flow on the left side. So we deployed the stent, ballooned it open. As you can see, there is no irregularity in the wall, and it's homogeneously opened. And then the final venogram shows complete patency of the stent, and this is the images before and after, where the patient had the port, complete occlusion, and this is after we recanalized the right brachiocephalic vein. Pressures improved, and there was no post-dialysis prolonged bleeding, and this remained patent for 5 years, unfortunately, until the patient expired due to COVID pneumonia. This is another patient, 26-year-old, with left upper extremity swelling, dilated collaterals, with history of lupus anticoagulant. You can see there's a severe stenosis of the brachiocephalic vein. So we got across the severe stenosis. It wasn't an occlusion. The wire, as you can see, is totally occlusive, and then we were able to angioplasty the left brachiocephalic vein, and we got excellent results. So we decided not to place a stent, especially that this patient was very compliant. And this was the images of their left brachiocephalic vein before and after angioplasty. We decided not to place a stent at that time, and actually the brachiocephalic vein remained patent for 6 years, just with angioplasty every 4 to 6 months without a stent placement. After 6 years, the angioplasty was too frequent, so we decided to place a stent at that time. This is another patient, a 46-year-old with left AV graft insertion 3 weeks ago, and then developed painful swelling of the left upper extremity after the graft was placed. And you can see the left brachiocephalic vein is totally occluded on the left, which explains the upper extremity swelling with multiple dilated collaterals, and that's the occlusion. So we brought the patient for a venogram, and as you can see, the patient had the right dialysis catheter because of the swelling. We couldn't use the graft. And this is a view where you can see only collaterals, but no presence of the brachiocephalic vein. So we're able to recanalize the vein and place a non-covered stent. But as you can see, there's actually some extract there, which we identified just angiographically, and immediately placed a covered stent, which provided better radial force in the uncovered stent and also sealed the extract. And as you can see, the right brachiocephalic vein is also patent. And the patient actually is now still patent 2 years as of now. This is another patient who had right upper extremity pain and swelling. As you can see, there's severe stenosis of the brachiocephalic vein with multiple collaterals. We opted to just perform angioplasty without stent placement, and we had excellent results. As you can see, the caliber of the brachiocephalic vein was likely patent. We instructed the patient to follow up with us to make sure that if there's any recurrence of the swelling, then we would intervene immediately. Unfortunately, the patient went for 19 months without any follow-up and lost follow-up with us, called us back 19 months later with recurrence of symptoms in the form of severe swelling. At that time, the brachiocephalic vein is completely occluded, so we decided to perform a recanalization. One of our techniques is to get multiple projections in 2 different obliques to be able to triangulate the connection between both veins. As you can see, we came through the right upper extremity and through the groin, and we did perform a recanalization. We were able to get the wire across, and then we deployed covered stents to maintain patency of the vein. The left side stents, as you can, left-sided veins is also patent and not jailed off by the covered stents. The patient's swelling immediately improved in a few days, and it remained patent for 3 years, unfortunately, until the patient expired due to COVID pneumonia. This is another right brachiocephalic fistula with severe right upper extremity swelling and decreased flows. As you can see, there's complete occlusion at the level of the junction of the brachiocephalic on the right and the subclavian. And we tried to perform routine regular recanalization using glide wires and catheters. Unfortunately, we couldn't, so we opted to do a sharp recanalization in a V18 wire. The V18 wires, when we cut off the tip, they become very sharp. We placed a Fogarty balloon within the right subclavian vein as a target and used a directional catheter going through the groin to advance the sharp end of the V18. It's the cutoff tip. To obtain access into the subclavian vein. Then we used a snare to obtain access to wire through body floss technique. And then after we obtained the access, we did some simultaneous venograms through the lower the right femoral vein axis and the right upper extremity axis to delineate the extent of the occlusion. As you notice, it's a long segment occlusion, which really was very tough to recanalize this. After we were able to obtain thoraxis, we deployed the Viator stent, and this was the final image after we deployed the stent with maintained patency, and this was the images before and after the recanalization. This is another patient with 70-year-old with left upper extremity swelling and pain for 4 weeks. As you can see, that there is a pacemaker with the subclavian vein completely occluded. We were able to recanalize and get a wire across, and then we angioplasted the subclavian vein, and it remained patent. So we opted not to place a stent as the patient was one of our institutional patients. So they had excellent follow-up with us and remained patent for at least 3 years. 42-year-old female history of lung transplant, and she was very complicated because she has exhausted all the right upper extremity access options and grafts, and she had a last resort left arm graft, a left upper extremity. Unfortunately, that graft was failing due to the arm swelling and pain and high pressures. So they were thinking the last resort was to go to a hero graft or groin access. The patient absolutely refused, and the transplant team to go to groin access due to high risk of infection in an immunocompromised patient. So they were really, as a last resort, they asked us to recanalize the central veins. As you can see, the central veins, there's no brachiocephalic vein, just the scar tissue that's calcified. And then we brought the patient for a venogram. As you can see, the brachiocephalic vein is completely occluded with only collaterals. So we're able to sharply canalize the vein and place a covered stent. As you can see, this is a combo of a Viator stent and a fluency stent, and this was before and after the images. We were able to actually bridge this patient for 5 years using the same graft, with maintaining patency of the central veins until she received a renal transplant at Cleveland Clinic. This is another patient, 59-year-old, who left upper extremity fistula, has an occlusion of the left subclavian vein. Which, as you can see, there's complete occlusion of the brachiocephalic vein, a subclavian vein, multiple collaterals. We tried all conventional wires, the catheters. We even tried the V18, wouldn't work. So we actually placed a metal cannula from the tips that we use to perform tips in the liver, and we obtained femoral access and placed a snare as a target and triangulated it, and then advanced a 22 gauge 55 centimeter Shiba needle through the metal cannula directed towards the snare. We were able to advance the wire, snare it through, and then place the covered stent, which maintained patency, and this helped resolve the swelling and the pain. This is another patient with a left subclavian vein occlusion, same exact story. Unfortunately, our regular techniques did not work, so we did the same thing. We placed the metal cannula from the tip set, used a Shiba needle, passed a wire, snared it through, and placed a covered stent, which maintained patency. SVC syndrome can result from obstruction of blood flow through the SVC. Malignancy contributes about 90% of those cases, although intravascular devices does have a role in that. We find the SVC syndrome patients due to malignancy easier to recanalize because it's an extrinsic compression / infiltration. These patients usually present with dyspnea, facial swelling, arm swelling, cough, chest pain, and dysphagia. Sometimes they actually develop severe cerebral edema or laryngeal edema and may actually go into coma just due to the SVC syndrome. Clinical manifestations, we usually on physical exam, we find a lot of dilated veins distended on the chest, arm edema, cyanosis, and facial plethora. Patients usually give us a classical history of gradually progressive symptoms over the past few weeks or few months. This is a patient with SVC syndrome, symptoms, and lung cancer. As you can see, their SVC at the brachiocephalic is completely fluid with calcifications. We're able to recanalize the SVC via groin access and angioplasty, the occluded vein of the 14-millimeter balloon. We got good, not fair, relatively fair results. However, we angioplasted with bigger balloons, and we got good venogram with the better caliber of the size of the vein. Unfortunately, the patient did not want to stent at the moment. So we followed them up at least for 2 years, and then unfortunately this just recurred and symptoms recurred. So the patient opted into receiving a stent, so we were able to place a covered stent in that location, and his facial swelling improved. Another patient with lung cancer, shown as birth typical SVC syndrome. As you can see, there's a mass obstructing the SVC in the brachiocephalic vein, and complete occlusion of the SVC with no flow and multiple dilated collaterals. We're able to get through it through axis, through the IG axis and the femoral axis. And this is a combo of 2 stents, an inverted Viator stent and an uncovered stent, that maintain patency to the left brachiocephalic vein, but at the same time avoids ingrowth of the tumor into the SVC. This is another patient with SVC syndrome secondary to a large lung mass. Patient had marked facial and neck swelling and required intratracheal intubation due to laryngeal edema for airway protection. His symptoms were really advanced. As you can see, the size of the mass is really advanced, and we're able to get through it through access and place metal stents to be able to maintain patency of the SVC brachiocephalic, and you can even see the left brachiocephalic patent. Thank you very much for listening. I appreciate the chance to present to you, and have a great day.
Xin trân trọng cảm ơn giáo sư Abouelmagd Makramalla đến từ Đại học Cincinnati, Ohio của Mỹ với cái bài giảng về can thiệp tái thông tĩnh mạch trung tâm phức tạp rất là hay, với nhiều ca lâm sàng rất là thú vị. Thì tiếp theo tôi xin giới thiệu bác sĩ P. Duy Trang đến từ